Good afternoon. I'm Nandakumar, professor at the Heller School, and will be moderating this panel, this exciting panel. Um, for those of you who are signed in, could you just mute your audios, please? It'll be helpful. Today's panel is the third in a series on COVID that has been organized by the Heller School. The first was on the South Korean response. The second was on the economic impact of COVID-19. And this panel will discuss the health system's impact, both in the US and globally. Before we get started, there will be a Q&A session at the end. Please post your questions on chat. Please keep your audio and video muted for the duration of the panel. We have an extremely illustrious panel: Professor Stuart Altman, Professor Christine Bishop, Associate Dean Maria Madison, and Associate Professor Diana Bowser. So a round of applause for the panelists. I'm going to give some brief remarks. This pandemic is like nothing like what we have faced in recent years. The health toll and the economic toll have been severe. So far in the US, close to 100,000 people have died, and globally, close to 340,000 people have died. We decided to have a very aggressive public health response to save lives, and our actions led to a severe economic impact where we have nearly 40 million people who are unemployed. We are losing between $350 and $400 billion a month, and our GDP is expected to shrink by about 40% this quarter. It's important to keep in mind as we have this discussion that pandemics kill in three ways. The first is the virus itself. The second is the disruptions to the regular healthcare system. And the third is due to economic disruption and all the stress that it causes. Pandemics also impact the poor, people of color, and other vulnerable groups significantly more, not just in the US, but globally, more than they do the middle class and the rich. The situation in low-income countries is far more dire than what we have here. For starters, they have much more fragile healthcare systems. And as it happened during the Ebola crisis, which many of us have lived through and experienced firsthand in the field, frontline healthcare workers and the primary healthcare system can very quickly get overwhelmed. And their economies are far less resilient than ours. Some of the analyses that are coming out show that in sub-Saharan Africa, because of COVID-19, disruptions to the healthcare system and economic impacts, we may lose 500,000 people to HIV, and there will be significant increases in maternal, neonatal, and infant mortality. Different choices, clearly difficult choices, have to be made, and these are never easy. What we have seen so far is that the debate and discussions have been dominated by the public health people. And there has not been an equivalent voice of the economists, the health policy experts, and the business sector. And globally, what is quite distressing is that the global dialogue has been marked by finger pointing, a lack of trust in global institutions, and a scattershot of responses. With this background, I'm going to now turn to Professor Stuart Altman with the first question. Stuart, given that the US spends a lot on its healthcare system, why is it that we are having so much difficulty tackling COVID-19? In your view, what has worked well and what has not? And given the experience with COVID-19, what are your recommendations of how we deal with health systems in the future? Over to you, Stuart.
Well, thank you, Nanda. And first, we're going to talk a lot about the problems with our system, but I want to start out with a strong shout out to the thousands of nurses and physicians. I think a fair assessment is going to show that in spite of the fact that we have not done well in terms of almost 100,000 now Americans dying, thousands of our citizens have managed to recover thanks to the work of these nurses and doctors. So let's not lose sight of the amount of good things that have worked well, but we need to focus on what hasn't worked well so we can focus on doing better if it ever happens again. And Joanna, maybe you can hit us with the slides, since I'd like to get them, but they're not here. Can you get the slides? What I want to show is, first of all, to recognize that good healthcare is for a population is far more than just healthcare. It involves what we call our social care services, or what we're now calling the social determinants of health. And the next slide, you'll see that when you look at most populations, next slide, you'll see that it really is a combination of social care services, a good, strong public health system, a backup system for emergency medical care, and a healthcare financing system that works. So let's focus on the next slide. And the next one, you'll see that when you look at all of the different components, next one, Joanne, you'll notice that healthcare itself is just about 20% of good health. Much of it is health behavior, socioeconomic factors, physical environment, and so on. And our next panelists, Christine and Maria, will focus on aspects of this social determinants that have led to populations and groups, like in nursing homes, which are not doing well. One of the things we've learned, however, is the next slide, please. When you look at the amount this country spends on these social care services, you see that next slide, that when you look at the United States, you'll notice that we spend only about 9% of our GDP on these social services, where every other industrialized country spends significantly more, 21% in the case of France and 20%. And as you move down the list, even the lowest ones in Canada are still above us. So we need to be focusing much more on these social services. Next slide, please. Now, let's focus on our financing system. Before COVID, most Americans rely on particularly for those over the age of 16 and under the age of 65, rely on their job and health insurance through their job. But what happens when they lose their job? And as you'll see in the next slide, this shows you the fact that that blue line is the amount of money, is the amount of the population that gets their health insurance through their job, with 16% from Medicare and 20% from Medicaid. But unfortunately, as Nanda has pointed out, the COVID has led to a massive reduction in employment. See the next slide, please. You'll notice a very sharp drop off or increase in the amount of people who have lost their job. And interesting, the number who are over 65 is actually higher than the overall population and is approaching 16%. So we have now a substantial reduction in our workforce, leading to a substantial reduction in employer-based insurance, which means we need to focus on the so-called healthcare financing safety net. And it depends critically on where you live. For those who are in blue states, for the most part, that expanded their Medicaid population under the Affordable Care Act, the social safety net is significantly better. But for those in states that did not, particularly states like Texas, Florida, and the state I'm now in, North Carolina, the underlying safety net is pretty ragged. So, next slide, please. No question, as we think about the future, there's growing support for a Medicare-for-All or a public option plan. Next slide. However, I think it's pretty clear that it is still going to be a very unlikely scenario that we will have a national program for either a Medicare-for-All or a public option. However, we could see some, if not many states, particularly so-called blue states, that will create their own public option. We already have one in the state of Washington, but you will see more pressure on the state level to develop public options. In addition, we need to strengthen our ACA safety net. Next slide, please. You'll see here in this slide that, as I pointed out, both a Medicare-for-All and a public option is gaining more support, particularly the public option. But there are very strong pressures that, as I said, that will make that very unlikely at the national level. So what we need to focus on as we look into the future is the following. We need to build up our public health system. We need to back up our acute care system with a true national emergency set of supplies for physicians and nurses that need personal health care backup. We do have a strong availability of ventilators and other high-tech equipment. It's one of the good things of a overly cost healthcare system, but we need to make sure we have a backup as well. And then finally, we need very much to have a good, solid safety net. We can talk more about these in the question and answers, but I now want to turn this program back to Nanda.
Thank you very much, Stuart, for both analyzing what worked well and what did not, but you have come up with some very concrete suggestions on the way forward. The next question is for Professor Christine Bishop. Christine, what is very clear is that those living in nursing homes and assisted living facilities have been particularly hard hit. In your view, what are the main reasons for this? And going forward, what kind of interventions are needed to protect the older adults, people with disabilities living in these nursing homes, and equally importantly, the frontline workers who work there? Christine, you're muted.
Thanks very much, Nanda. And coronavirus certainly has hit older adults extremely hard, especially those who are living in congregate settings. This is happening almost everywhere in the world, by the way. But I'd like to bring it closer to home. I know our audience may be actually national or international, but Massachusetts has had a particularly interesting trajectory. So I wanted to bring it close to home to Massachusetts. So we need to stop the spread of COVID in nursing homes now, but also to look ahead, as Nanda says, to how the nursing home sector and nursing home policy need to change. By this Sunday, these are very current numbers, Massachusetts has experienced 6,372 deaths from coronavirus. This is all the population of Massachusetts. Another click will show you that 61% of those deaths were in nursing homes. And there's another way to see these numbers with another slide click here. This kind of puts this shows you the total in the dark blue line and the deaths reported in long-term care facilities in nursing homes in the light blue line. There's still another way to see this, if Joanne would click again. And this shows with the light blue line, that's the nursing home deaths, 3,890 since the beginning of this epidemic. And the dark blue line shows the Massachusetts deaths without the nursing home deaths. So that gives us something to think about. It kind of puts a different spin on it. Only 25,000 deaths among 7 million Massachusetts residents who don't live in nursing homes, and about 4,000, almost 4,000 for the 39,000 who live in nursing homes. They are our older relatives and parents and grandparents and our retired colleagues and veterans who've preserved our way of life. Why didn't we see this coming? Clearly, public health in Massachusetts was caught off guard, and this happened all around the country too. Their focus was understandably on hospital capacity, on ventilators for ICUs and protective gear for hospital workers, and on halting the community spread. And as Stuart mentioned, this is a success story in that many people did recover, and I believe our sheltering in place has kept more people alive. With the next slide, you can see a headline, though, that woke Massachusetts up. This is from March 30th, where it was announced that 11 residents of the Holyoke Soldiers Home, which is operated by the Commonwealth, had died. And this was a wake-up call in late March. And a few other nursing homes became hotspots as well. And the first reaction, as it often is in the nursing home sector, is to blame the nursing homes, the individual providers on their own or in corporate chains, or the commandant of this soldier's home. And observers' first hypothesis is always, in this kind of situation, that this is due to especially poor care. They're bad apples in the nursing home sector, both for the first infection and for the spread among residents once the virus has gotten inside a nursing home. But actually, this doesn't hold up. Our data is not very good yet, but we know a lot about nursing home quality and nursing home activity from regulations and reports that have been done over 20 years now and more. And early results using multivariate analysis show that neither a poor quality rating nor low staffing was associated with the first incursion of the virus into a nursing home or its spread. The culprit seems to be simply traffic into the nursing home. How many different staff are entering each week? How big is the nursing home? What's the disease prevalence in the nearby community where it's located? So good, in quotes, and bad nursing homes got hit alike. In the next slide, you can see that Massachusetts data collection on this wasn't started until quite late, but this is the number of nursing homes with at least one case. And that has steadily risen over all of these weeks through April and May. And it seems to be heading asymptotically toward our total number of nursing homes, 388. There are cases of coronavirus in almost every nursing home in the state. So when the virus comes in with one staff member or visitor and infects residents, it's very hard to keep it from spreading, especially without personal protective equipment or extra room for isolation. And this is due to fundamentals of the nursing home model, that older adults with multiple chronic conditions are living in very close proximity. They're eating together. They have common rooms that they spend time together and activities. And as a matter of fact, people with dementia don't do very well with self-isolation and keeping to distancing rules. So you might say, is the nursing home simply doomed? Maybe we should let it go. Older adults are staying in their own homes longer and in more home-like settings otherwise for just as long as they can. Medicaid has been trying hard to rebalance toward community-based care. And prior to the pandemic, a whole set of factors have pulled resources out of long-stay residential care. And of course, this is why these facilities have so little resilience now in the face of this crisis. They simply don't have the cash for tests or personal protective equipment. But some people still need nursing home level of care. And that number is going to grow as our baby boom generation reaches prime nursing home utilization years. So maybe we have to make up for past disinvestment in this sector. The first thing I'd note is physical capital, bricks and mortar. Nursing homes now have double rooms and shared bathrooms. Those are much cheaper to build, but residential nursing home care would be less open to contagion with a different physical configuration. For example, single rooms with private baths, smaller pods of residents, and this is part of what's known as culture change, the idea of getting residents into smaller households where their interactions are mostly with 7 to 10 other residents and just a few staff who are assigned to them. Or even the greenhouse model, which you may have heard of, which is small residential communities in separate buildings where there are, again, 7 to 10 residents and just a few staff who do almost everything for them. But the most important thing here is the staff. They have low pay now and very poor job quality. The certified nursing assistants especially, they're working in nursing homes and their situation generates exactly the problem that have led to COVID spread. Certified nursing assistants in Massachusetts earn less than $15 an hour on average. In other states, they earn even less, even as low as minimum wage. And ancillary personnel are earning very low wages also. I'd like to show you a slide from my colleague Courtney Van Houtven from Duke University, which highlights the factors that have fueled this conflagration from a staffing point of view. You can see that 70% of these workers feel obligated to come to work, and many do not have sick pay, even when they're sick. 1/6 had a second job, and that means they're going back and forth to other jobs and can be infected and be asymptomatic carriers of this disease. And many of them hold double or triple duty caregiving roles at home or outside their homes, where they're caring for family members and children and friends and so on. And again, this is a way that this population in particular can be affected by, or can get infected with this disease and carry it in. So now dedicated staff in this time of crisis are calling in sick because they're sick and because they're afraid for their family members and the other people that they care for. And they're leaving the nursing home understaffed and increasing the stress on their coworkers. The current strategies include forbidding workers to have a second job, which is hard to adhere to, hazard pay to keep workers on the job, and state-provided personal protective equipment. So Massachusetts has stepped up with testing and some funding for PPE, but not until mid-April. And I can talk about what's been done if people are interested in the questions time. Massachusetts has started an employment portal, which frankly hasn't apparently worked very well, but to try to get more staff to work in nursing homes at this time, and has a kind of SWAT team, has some teams who will come in and help, and it's not clear how that's working either. There have been a few homes around the country who have set up places for their workers to live so that they can be isolated for 2 weeks at a time and work 2 weeks on and 2 weeks off, and this is a way to contain the virus. So in the current crisis, the Commonwealth did finally step up and provide extra funding, an influx of cash. And these policies show some creative ways to get people back to work, but there's a long, hard slog still ahead. And I haven't even mentioned how the nursing home pandemic crisis has affected the availability of post-acute care for COVID patients recovering after hospitalization, post-acute care for all sorts of other conditions that where people need skilled nursing facility services under Medicare, palliative care and hospice care for people who are dying in nursing homes and are not allowed to have their relatives with them, but also don't have support of others, other staff coming in for hospice and palliative care, or the effective strategies that would move residents to be COVID only or COVID free. And the impact, of course, is also strong on assisted living and continuing care retirement communities and group homes and independent older adult housing. There are good stories too. I was heartened to hear that alumni of a choir that I sing with who got coronavirus, they're a couple in their 90s living in a nursing home, and they've both recovered. So this is happening also. And I believe what we're experiencing, trying to beat this virus on the fly, can inform how residential services for older adults and others who need care can be structured and financed for the future. And I'll be very interested to hear your stories and questions when we have a chance to talk more informally.
Thank you, Christine. I think, Stuart, both you and Christine have raised a very important point. I just wanted to raise this, and we'll hold it on the parking lot, that how Medicaid and Medicare, which are big payers of long-term care as well as a general healthcare system, sorry, we can hear somebody on a phone. So what seems to be happening is that both Medicaid and Medicare, the way they have been funding, right, the healthcare system has forced people to go to extremely efficient, and efficient, yes, Christine, what we have done is we don't have much slack in our healthcare system, right, to respond to these shocks. And we also, by its very nature, seem to be having a system where we need to have people who are willing to work at the minimum wage to provide some extremely important services. And so it kind of bothers me a little bit, because one of the solutions seems to be that we not only need to increase our spend, but also pay people better so that it works well. And my concern is if we transpose this to a single payer model, and the single payer model starts resembling Medicaid, what spillover effects it will have on all aspects of the healthcare system. So hold this thought, and I'm now going to move to Maria. Thanks, Christine. So Maria, thanks for joining the panel. What is very clear is that COVID-19 is impacting the African-American community. Oh God. Is impacting the African-American community, other minorities, those living in poorer neighborhoods, and anecdotally, illegal immigrants disproportionately. So in your view, why is this happening? And what are some of the key policy interventions needed to protect against this in the future?
Thank you, Professor Nandakumar. I am appreciative of the ability to bring a multidisciplinary lens to those questions, not the least of which is in great thanks to the historian, for example, Ibram Kendi, who I think it was around April 1st, was one of the first to ask, where are the demographic data that explain who's most impacted or disproportionately impacted by the morbidity and mortality of COVID-19? And certainly with the beginning of those questions, we began to see a gradual light being shed on statistics that show, for example, that while Blacks may only represent 14% of the population in some counties, we were seeing up to 70% of the COVID deaths in the same populations. So what I would like to do in answering your questions is to use art and history, along with epidemiology, to help shed light on what's occurring in this public health crisis, where we continuously are looking and calculating risks versus benefits, commercial interests versus civic duty, and public health versus economics, when what we really need to be doing, and Stuart and Christine, I think, pointed to this a little bit, is to help these dualities work in tandem. When these variables are out of balance, we see these COVID-19 stark disparities. And it's where underserved, discriminated populations are at the intersections of people who have been historically disparaged. Let's stay on the first slide, Joanne. In the US, the list includes Black and brown folks, Asians, Muslims, Indigenous. We've heard all the stories. The undocumented migrants who are residing in our communities. The disproportionately incarcerated, including youth, migrants, elderly, particularly their peers of color in those nursing homes that Christine was speaking about, and the LGBTQIA and the disabled. These folks share a common experience of being considered expendable too often throughout at least our American history, but this is a global story. There's no better time to grasp these stories than as the summer is approaching. And in particular, we're also being asked to begin to ease up on our physical distancing. So as seen in this quintessential 1840 painting by the British painter Joseph Mallard William Turner, at first glance, it looks beautiful, like a sunny day, somewhat like today, that we're seeing at least in New England, with bright and warm colors calling us out of our quarantine. We want to return to golf when we see golfers in the media, or simply jog without the risk of being murdered, or arrested for wearing a mask, or shot in a bed like the EMT Breonna Taylor. If you look closer at this painting on the lower right-hand corner, you'll see bodies in chains thrown overboard. The title of the painting is actually The Slave Ship, Slavers Throwing Overboard the Dead and Dying, Typhoon Coming On, almost like the second phase of COVID-19 that we're all dreading. In this case, it's enslaved cargo were being thrown overboard in order to collect insurance, demonstrating this historical trend where some bodies are more valuable dead than alive. This is a scene repeated throughout history in myriad ways, whether through broken treaties, as in the Trail of Tears, internment camps, or Hurricane Katrina. On the return of soldiers of color in honor of yesterday's Memorial Day, being segregated to lower resourced communities while their non-peers of color benefited from GI bills. Blacks were discriminated against through predatory lending or zoned into areas laden with environmental pollution, such as the lead in the water of Flint, Michigan. So marginalized populations are disproportionately impacted by disasters and historical disease outbreaks. Because of this calculus of the value of these lives weighed against commercial interests, for example, we can look at this pandemic through the lens of consumers and producers of health services to understand the political determinants of health. Within the political determinants of health resides the social determinants of health, but we really need to start by looking at that top layer where we see government, voting, and policy as helping us to play these themes out and aiming towards a more equitable solution. So we can see particularly that this pandemic really is shining the light on historical othering in accessing health equity. Next slide, Joanne. The epidemiologists Krieger and Chen, for example, described through their analysis of recent census data and geocoded data that the disparities are associated with those living in the most disadvantaged counties in this country, in particular those in poverty, those living in crowded situations similar to what Christine just described. And we know that not just those living in crowded or congregate situations, but particularly those of color in those situations. And that within those populations, they're experiencing six-fold greater death rates than their white counterparts. So while it's true that crowding, poverty, and being individuals of color are more likely to experience this excessive death rates from COVID-19, we know these are also historical trends, right? It's only part of the story, for example, is Black women who for every class still experience maternal mortality at rates far greater than white women. So the divide is made even more stark during COVID-19. And there's a variety of data showing this, not the least of which includes through ProPublica and referenced by the bioethicist Dorothy Roberts. So what are some of the key lessons then? Well, we can learn the lessons through history and also by looking at what's going on around the world in various countries. And what we see is those countries who seemingly have done a better job in responding to COVID has a lot to do with the governmental structures, how rapidly they responded, and the cultural humility they brought to that response. In the Taiwan experience, they listed as an important variable to respond to COVID-19 the need to consider both reducing stigma and increasing compassion around the epidemic. But we see that COVID-19 lays bare these intersectional vulnerabilities, as beautifully described, for example, by Kimberly Crenshaw. We see racism, patriarchy, and ignorance are the risk factors. In this country, through, for example, the legacy of Jim Crow. We know, for example, that Black Americans and other marginalized populations are more likely than whites to experience discrimination, and especially transgenerational discrimination that increases the likelihood of homelessness, exposure to food deserts, joblessness, educational barriers, becoming the low-wage frontline healthcare workers like the certified nursing assistants, or gig workers like bus drivers, food service workers, janitors, cashiers, and those who work at our local grocery stores. Those individuals are putting their lives at risk at increased exposure to SARS-CoV-2. I could show you numbers and data, but putting faces and names on it is equally important. Like Jason Hargrove, a bus driver in Detroit who posted a viral video stating that a passenger coughed repeatedly on him while he was driving the bus. Or 27-year-old Leilani Jordan, a grocery store worker in Largo, Maryland, who wanted to make sure people had their essentials for the quarantine. Both died of the coronavirus. So yes, marginalized populations are often living in higher crowding settings, making distancing difficult, and having less access to PPE, and have experienced a history of trust violations in the health sector, increased exposure to environmental pollutants, increased exposure to food deserts. They're also the primary targets of hate crimes, as reported by FBI statistics. They're also the targets of health providers' ignorance, bias, and bigotry. These are the circumstances that exacerbate life's stressors and predispose, for example, Black Americans to being overrepresented among those living with underlying health conditions, such as we're seeing asthma, diabetes, high blood pressure, heart disease, as often the result of historical discriminatory practices embedded in the structural and political determinants of health that can put a person at risk of becoming seriously ill or dying due to the coronavirus. Next slide, Joanne. So inequality didn't cause the coronavirus, but it is making the crisis much worse, having created an economy in which many Americans are struggling to get by, while others are doing exceptionally well, as you can see in the slide on the left and the chart on the left, where the very wealthy are experiencing after-tax incomes rise much faster than GDP, 420% since 1980. And we can imagine what happened, for example, related to policies in the 1980s all the way up until today. So again, inequality didn't cause the coronavirus crisis, but it's making the crisis worse, having created an economy in which many Americans are struggling to get by, and we know who those are, and are vulnerable to an interruption of work or income and any illness. And we can see in the chart on the right, in particular, that disparity. So what key policy interventions are needed to protect against this in the future? Well, first of all, we need to tailor, target, and prioritize the policies that have been proposed, that are somewhat enacted right now, and focus them more on the vulnerable among us. What doesn't work is to look away, as the virus anywhere is a virus, potentially everywhere. But in the short term, we need to make sure we assure the basic human rights for all. We need to include the rights and dignity to safety for workers. We need to protect people against violence and hate crimes. We need to assure free access to food, healthy food. We need to assure access to clean water, shelter. In the way of shelter, we know there have been moratoriums on evictions and foreclosures, but those are already being ended in some states. We need to assure, as was already or previously mentioned, that there's access to not just jobs, but meaningful jobs and fair wages. Why not reconsider a new version of the WPA? We need to consider providing educational opportunities at every level, particularly college debt forgiveness right now, where women, I think, represent something along the lines of 75% of that debt currently of new college graduates. And we need to ensure, as Stuart and Christine mentioned, that there's access to free and affordable health services, but that's physical and mental health. In the medium and the long term, we really need to focus on a new normal. And the best way to get to the new normal is framing political determinants of health, where voting is what's essential. And we need to demand that the elected officials support the policies that bring these services to the people who need them. In particular, the most important new normal, again, is to vote and invest in human capital and human potential. Thank you, Nanda.
Maria, thank you very much. That was, in 7 minutes, you were able to cover a lot of ground. And already the chat lines are, are very active. But what's interesting is you also brought out the fact that maybe the COVID pandemic has highlighted historical policies that have only exacerbated inequities as opposed to closing the gap. And that in addition to the social determinants of health, we should look at the political determinants of social policy and health and see how we can use both to look at those who are most in need, right? Yeah. So I think that was wonderfully put. So, so I'm now going to turn from a domestic focus to a global health focus and pose this question to Associate Professor Diana Bowser. So Diana, in the context of low-income countries, and you know this well, that while the US may be spending, over $10,000 per capita, we have countries in sub-Saharan Africa that are spending between $50 and $100 per capita, right? And about 85% of the global burden of disease is in countries that are spending 15% of the global spend on health. So in the context of low-income countries, what are some of the key similarities and differences that you were able to observe between the Ebola crisis and the COVID pandemic? The other thing is that it is not clear that most of these countries will have the luxury of first saving lives and then figuring out how to save jobs or the economy. And then when the pandemic hits, it is going to kind of disrupt both the demand for essential healthcare services and the ability of the primary healthcare systems to respond to this. And this can have significant impacts on the health and well-being of populations. So in your experience, you've worked in many countries, what do you see happening in these countries and what steps can be taken proactively to deal with these issues? Over to you, Diana.
Okay. Hi, everyone, and thanks, Nanda, for this great question. I'm delighted to be on this panel and hearing about the COVID response from many different angles, and I think it's really important to think about the low-income settings. Just for everyone on the call, there's no PowerPoints for this last section, so don't worry about watching your screen. You can just listen. So I think it's really important to look back at the Ebola pandemic, and I think since COVID began breaking out in countries around the world, in all of the meetings we've been in, we asked that question, what can we do? What can we learn from the past that can help us to understand what's going to happen now with COVID in countries around the world moving ahead? And so we've been looking back at the Ebola pandemic and the outbreak there, which was very different than COVID. And I'll talk a little bit about the differences and the similarities in order to learn and see how that can impact what's going on in countries with COVID. So if you look at the Ebola outbreak and compare that to the COVID outbreak, I think two of the differences immediately that we need to think about have to do with what we hear on the news about COVID. and that has to do with mortality and contagion. So the Ebola outbreak, for those of you that are remember, back in 2014, 2015, was mainly an outbreak of West African countries, 3 main countries, basically, although it did spread to several other countries. And the Ebola pandemic was more, that had more deaths than it was contagious. So if you look at the case fatality ratio of the Ebola outbreak, and that is just a simple comparison of the number of individuals that die of the disease divided by the total number that are infected by the disease, it was fairly high in the Ebola countries. It was upwards of 50%. So if you happen to be in a place where Ebola was, where there was an outbreak of Ebola and you became infected, you have a 50% chance of dying of the disease. And while it was contagious, and it is a contagious disease, it's mainly spread through the touching of bodily fluids. Unlike the COVID pandemic, as we know, which is much more contagious because it's spread through air droplets. So I think thinking about these differences in the outbreaks is really important when you're thinking about the impact on populations and, more importantly, the impact on health systems. And then with regard to the mortality from COVID, we see, and the numbers are still coming in, and in order to get these numerators and denominators correct, you have to make sure that you have the total number of deaths counted correctly, and of course, obviously the number that are exposed and become infected with the illness. But none of the case fatality ratios that I've seen in countries around the world are approaching the 50% rate in the Ebola countries. And a new Health Affairs article that just came out did some projections and models of the US case fatality ratio for COVID, and it's much lower across the United States anyway, between 1% and 5% case fatality ratio, depending on which state that you're in. So I think these are important differences to think about. And then obviously, the Ebola outbreak was contained in several countries, mainly in Western Africa. Around 11,000 individuals died. It was not considered a global pandemic. The COVID outbreak is a global pandemic, killing upwards now almost 100,000 deaths in the United States and reaching almost 350,000 globally. So those are the sort of key differences that you have to think about when you're thinking about these different outbreaks. So with regard to the similarities, I think it's really important to think about, regardless of the mortality and the contagion, outbreaks like these can have devastating impacts on all health systems, regardless of income level, low income, medium income, and high income countries. So I think it's important to, again, look back at the past and see how we can learn from that. And I will give a warning for low income countries. I do believe it's going to get worse before it gets better. Where our curve was a little bit behind Europe's curve, right now we're seeing in Latin America, the number of cases and deaths is increasing dramatically as we speak today. Chile and Brazil are now having increased number of cases. So I think some of the countries that I work in, I've talked to colleagues over the last few days in places like India and Haiti, Rwanda, Ethiopia, and their cases are on the rise, and they're definitely worried. So I think in these low-income countries, you have to think about some of the health system issues that you need to take into consideration in any epidemic, but thinking ahead now to COVID. And I think one of the important aspects to think about is on different levels of your healthcare system. At the higher level, at the primary care level, and then also with regard to the public health response. So in low-income countries, at the higher level, and again, if we look back to the Ebola crisis, they just didn't have the infrastructure to deal with the high number of extremely sick individuals that were dying of the Ebola outbreak. So the WHO, the US, many other donors had to bring a lot of infrastructure to those countries, healthcare workers, PPE, protective equipment, et cetera. So I think we need to think about what would the response be in low-income countries as the number of COVID cases increases in these areas, given the restrictions on travel, given the fact that many of these donor countries are dealing with their own outbreaks. So what is the impact going to be on those higher level healthcare facilities? And then with regard to the primary healthcare facilities, again, looking back at the Ebola outbreak, and as Nanda mentioned, we can learn from the past, the primary healthcare facilities suffer just as much as the tertiary healthcare facilities, even more. In the Ebola countries, the research has shown that primary healthcare facilities shut down. Healthcare workers don't go to the facilities because they're afraid of catching the illnesses. And individuals and patients don't go because they're afraid. So, and as a result, in some of these Ebola countries, what we found is the incremental deaths from some illnesses like malaria was even higher than the deaths from the Ebola outbreak. So I think this can have a huge impact in low-income countries with regard to many of the important public health interventions: maternal, child health, vaccinations, all the people that rely on drugs and services for HIV, AIDS, TB, and malaria. So we have to think more broadly about the incremental effects from these other illnesses. And then finally, I'll talk quickly, because I know we're running out of time, about the public health response. That public health responses involving social and behavioral change are extremely hard to implement in all countries around the world, again, regardless of income level. But I will say that I worry a little bit about some particular factors in low-income countries that might make this public health response even more difficult. So for example, very crowded urban areas, and we're seeing right now some outbreaks in Brazil in some of these crowded areas. Intergenerational living, where grandmothers and grandfathers are living together in the same household as young family members. So then you have sort of a natural exposure of the less vulnerable to the more vulnerable. Household living conditions. I mean, we're expected to wash our hands with soap as much as we can. Some of these households don't have running water, and they don't have access to soap and hand sanitizer that we have here in the United States. And then finally, testing is such a big issue here in the United States. I wonder and I hope that low-income countries are able to garner the testing capabilities in order to make sure that they have the numerators and the denominators correct. So I'll end on the silver lining, because I do like to end on positive notes. I would say, and I hope that some low-income countries might be able to handle this response better than others. And there may be some case studies. They've learned from outbreaks, they've learned from other pandemics, they know how to deal with people that have HIV, TB, malaria. They do contact tracing for these diseases. So there may be some countries that are able to garner a more robust community effort around these diseases. And I hope that we can learn from some of these case studies. So I don't, unfortunately for low-income countries, Nanda, I think we have more questions than we have answers right now. But I've just sort of outlined my worries and my concerns, and I'm happy to answer any questions from the audience.
Thanks, Diana. Thank you so much. I mean, yes, we certainly, for low-income countries, we have more questions than answers at this point. And we have a robust set of questions from the audience, which I'm going to, given that we have about 15 to 20 minutes left, I want to put them into three buckets. The first one really is addressed to Stuart, and it's really about why we consider that a single payer system or a universal healthcare system that is a single public option system not feasible, given that the savings from Medicare would be sufficient, savings from administrative costs of private insurance would be sufficient to sufficiently fund a Medicare-for-all system. In this context, one other question that came out was that if we moved to such options, the public health options, then what does it mean for sovereign nations that reside, of the native, for example, Native American populations that reside across multiple state lines? So Stuart, the first question is, why is a single payer system not the way to go? Just the savings would give us enough money to spend, and why aren't we doing this?
Nanda,
yeah.
You know I love you, but what you just said just isn't true. There is no serious analysis that suggests that the administrative savings that would come with a single payer come even close to what it would cost to generate a Medicare for all or single payer system. So we would have, so let's look, I think this deserves a very long discussion, but let me contrast the long-term care situation that Christine did such a good job of explaining to our hospitals. They are totally different systems. And the reason why they're totally different is that most nursing homes depend almost entirely on Medicaid funding. The ones that are funded by private aren't even in the statistics. And what happens in the hospital is that the hospitals rely extensively on private insurance, which is paying between 100 and 200% more than Medicare and 250% more than Medicaid. So as a result, our hospitals and our doctors have adequate private money. If all of a sudden that private money would be eliminated, we estimate, and everybody that has looked at this shows the same thing, we would face between a 20 and 35% reduction in revenue with Medicare and Medicaid funding. Now, it's possible Medicare and Medicaid would increase their funding, and that would be okay. However, the likelihood that happening with the serious deficit is very unlikely. So it's not that I'm against a single payer approach, but two things. First of all, politically, nationally, it's almost can't happen. And B, we need to be very careful, and those of you who are big advocates need to be very careful, particularly for vulnerable older populations. Medicare lives on the back of private insurance payments. So when I went into the hospital and spent 6 weeks in the ICU, much of the money was paid for not by Medicare. Medicare did a great job to protect me, but the hospital got substantially more money from the private sector. So Nanda, I love you, but there is no evidence that the administrative savings would be adequate to totally pay for the added spending.
Stuart, thank you. I mean, no, I tend to agree with you, but this was a question that I consolidated 4 or 5 streams of questions that came through the chat from
that I saw that, but
from the audience.
I know you and I are on the same page on this, but I needed.
But the second question again goes back to the inadequacy of Medicaid payments, and this is a question that really asks that given the inadequacy of Medicaid payments, Maria and Christine, how do you think that given how little we spend on Medicaid and the inadequacy of payments, unless there's a fundamental change to that, how possible would it be to improve, treatment in nursing homes, communities of color, and other disadvantaged populations, even if you just looked at the COVID response?
Christine, you want to go first?
Sure. Medicaid really needs to carry more of the freight in the nursing home. It's been, money has been pulled out from the private sector. As Stuart mentioned, we don't have private pay residents there anymore. And Medicaid was used to paying marginal cost, and they really do have to start paying average cost in the nursing home. Yep. And it's if they expect nursing homes to exist into the future. Some people would think it's fine that nursing homes are not going to exist into the future. I think it would be very dangerous to let that whole sector go. So I think Medicaid systems will probably respond to more nursing homes going out of business, but I hate to see that because it's the better ones that use their resources for something else and leave the business. One solution that's been put forward is to federalize Medicaid for this particular sector, and that could bring more money and a more equitable system to bear. But again, with the deficit that we have and many things that we need to spend money on, that's a challenge too. I did recommend that we have revamping of the nursing homes. Maybe they will be smaller. Maybe they will serve a smaller proportion of our older adult population with disabilities, because we do have home care that's getting better and more effective, and home visiting by physicians and the like that's getting better. But for the nursing homes that are left, I think they do have to be reconfigured.
I would just completely agree with that, but particularly the federalizing, that's particularly, I think, the highest likelihood of creating an equitable approach, particularly since, and Christine, you know this data far better than I do, but the proportion of African Americans in nursing homes, particularly tiered by quality, are congregated predominantly in the lower invested in nursing homes. And so that's why we see some of these disparities in COVID-19 death rates, particularly Black, white, because it's just not, it's not necessarily an accessible resource for our Black communities to put our elderly into those better equipped facilities. And that those facilities should be located within the communities. And I would hope that a federalized approach would locate such facilities closer to our communities.
Thank you. And Diana, there are a set of questions that have come in, and I'm going to bundle them in terms of the global health space, right? So before I pose the question to you, I think when we look at a response to a pandemic, looking at a response to the pandemic and the healthcare system, underlying healthcare system separately, is probably not the way to go in any country, and especially in low-income countries, because the strength of the underlying healthcare system is going to determine how these countries are going to be able to respond to any crisis like the pandemic, right? And so health system strengthening becomes as important as being able to respond quickly to pandemics. Given this, the question really is that what are your recommendations to coordinate the national and global efforts for the production of vaccines, tests, other supplies, so that there is equity in both the production of these commodities, the paying of these, the pay for these commodities, and the distribution of these commodities? What would your recommendation be? A very interesting thing that came out in DevEx today was the recommendation to create, like the Office of the Global AIDS Coordinator, where I also sit, an Office for Pandemic and Health Systems Response being driven out of the State Department. So we replicate what we did for HIV, malaria, and TB for pandemic and health system strengthening. So the other question that came up was that why is it that we are seeing that countries like Thailand, and there are other cases in Asia, are seeing so few cases and a very limited spread? Do you have any suggestions for that? So these are the questions.
I'll take the easier question first. So I think it's going to be really interesting when we look back on this outbreak, because there is quite a bit of variation across countries, and countries like Thailand and others that came out very early and had very strong enforcement of public health policies and social distancing measures. You could make a correlation between those and those that have done a better job in terms of containing and testing and whatnot. I will say about the case of Thailand, I mean, we've been watching that country for a number of years, and they've done a very good job of investing in their primary healthcare system for many, many years, from 1970 onward. And I think as a result, they have a robust primary healthcare system, probably a robust way to deliver some of these public health responses very quickly to their populations with community healthcare workers, community nurses. So I think looking at interventions like that in countries are those countries that are going to be able to more robustly respond to these outbreaks. And there's a handful of countries like Thailand that have spent a lot of time investing in those primary healthcare systems. If you're now trying to invest in your primary healthcare system as the COVID outbreak is happening, it's really not going to work. So those investments need to be made early. With regard to the response, yeah, that's a hard question, because what I would like to say is that there could be organizations like the WHO or the United Nations who might be able to take on a global response in some ways. But there have been examples in the past where these organizations haven't done such a great job responding to some of these outbreaks. So I do believe that there needs to be a concerted effort. I'm not sure where it should be housed. I do think that we've had good experience in the past in terms of concerted efforts around financing. If you look at examples like the USAID's efforts around HIV/AIDS, the Global Fund efforts around HIV, TB, and malaria. I mean, I think there's examples of how financing efforts can be pulled together to create a cohesive effort on these different topics. I think the financing question now is, all countries are under stress, so is there going to be additional dollars and incremental efforts that can be put together? So those are sort of my two responses. Again, more questions than answers, but those are my ideas.
Thanks, Diana. I think, Maria, you wanted to add something?
Yeah, so so many countries with varied experiences and sometimes having similar outcomes. But Taiwan is another example, and what we should raise is how they were able to leverage big data analytics, for better or for worse. The role of new technology and proactive testing, along with their previous experience with other coronaviruses like SARS. So they were planning since those earlier epidemics. And they included in the planning from those earlier epidemics how to do things like real-time alerts, using technology, QR codes, SMS, as well as toll-free numbers. So technology, pros and cons, has made a difference.
Right. So I think we have a couple of minutes left. There are a number of very interesting questions that are still coming in, and it's really about the public health option, Medicare. There are payments and trade-offs between these various approaches to restructuring the US healthcare system, and as well as some questions on the global health side. What we might want to do is, I want to give each one of the panelists about a minute for concluding comments or remarks. I want to thank the panelists, and I want to thank the nearly 250 people who signed up and who participated in this panel. It's been very rich. Maybe we'll consolidate these questions and see whether over the next coming weeks, we can come up with some responses that we can then post as a Q&A on the Heller website. So with that, I want to turn to Stuart first. Stuart, for your concluding comments and remarks.
Well, let me, I went through my presentation fairly quickly, but one of the areas that is deserving of a lot more discussion is the possibility that states will develop what we call public option plans, and which is a way of strengthening the safety net without destroying the private side. If I know there's a number of the people who are listening who would love to destroy the private insurance industry, but what we need is the funding that comes from private sector. And the public option would develop an increased public side without destroying all of the private side. Because I fear that if we go to an all public finance system, we will very quickly become an underfunded healthcare system. And looking at other countries really doesn't help. America, for better and a lot worse, we're just different. And we could wind up where our hospitals begin to look like our nursing homes. And you don't want that. So my plea to everybody is we need to strengthen the Affordable Care Act, potentially put in a public option, and make the safety net real, particularly in states that have not expanded their Medicaid program. It's a shame what they're doing in Texas and Florida and places like that for their low-income populations.
Stuart.
By the way, I left out a discussion about our national leadership because I feared if I got going on that, my 20 minutes would have been, we need better national leadership, no question about it.
Christine, your concluding thoughts, please.
Absolutely. The nursing home is a special case within care for people who need functional support. And it's very clear that there are other parts of this system too, home care and so on. And those parts of the system also have not been getting the kind of support that they need. In fact, I had a question from a journalist yesterday about who should be responsible for providing PPE to the personal care attendants who are working with people with disabilities under Medicaid everywhere. And it's very challenging in this kind of a situation to get those things out there through a fragmented private system, a system that has the Medicaid and a lot of private players, and who is responsible when you have something that really needs to be handled collectively. So I hope we can think about that for the next, before the next epidemic hits, and do a little bit and do more thinking about the sharing with each other and being more collective about some of these issues in long-term services and supports, especially because it's a burden that many families have in terms of caregiving, and something that will affect many of us. So that was the thought I'd like to leave you with.
Thanks, Christine. Maria?
Thank you. I would end by saying find a way to create your own or join a mutual aid network. I know there are pros and cons to them, but I think the urgency of now are those populations who don't access or are not in our healthcare system for various reasons, whether undocumented or just don't trust the system because it's failed them in the past. Those are the hotspots of tomorrow's second phase. So find or create a mutual aid network to make a difference among those who are most vulnerable, because it helps the entire society. And that's while waiting for and lobbying for a national transformation in leadership. To Stuart's point, vote.
Thanks, Maria. Diana?
Yeah, just a few final comments for low-income countries. You know, I think we have yet to see what's going to happen in some of these countries. We're waiting to see, and I hope your cases and your numbers stay low. I do think that there's lots of innovations that happen in low-income countries that we can't forget about, and those can be used to your advantage during this COVID outbreak. And I will say one thing that didn't come up on this panel, but has come up on other panels, is the use of telemedicine and other types of virtual visits, which we've had some luck now here in the United States. And we've been trying this in low-income countries. So again, maybe this is the silver lining of COVID in some of these low-income countries to improve access to virtual visits and telemedicine for all primary health care.
Thank you. I just had three comments to make, and then I wanted to thank everybody. The first one is this pandemic has shown us how interconnected global health systems really are. And in terms of just looking at the global supply chain for ARVs, actions taken by India, for example, have disrupted the supply of ARVs to the most needy people in Africa. Right. And then we're talking about the category of vaccines and tests that can be considered global public goods. So that it shows us that we have still not found a way to deal with global public goods and global the intermeshing of systems like global supply chain. So that's going to be very important for us to consider. I really want to take this opportunity to also thank Joanne and Andy, who have been absolutely phenomenal in pulling this whole thing together. And to each and every one of the panelists for your contributions, and to all the people who participated in this. Thank you very much. This is an ongoing dialogue, and we'll keep this going. Thank you.